We went to look at an adaptation towards product certification instead of accreditation. That would mean that we would make a new set of general standards. They were assessed by the College of General Practitioners, not alone anymore, but also by patients, also by healthcare insurance companies, and also by the Inspectorate of Healthcare. As a matter of fact, they would be in an independent college that would approve the set of standards that were proposed. So that's of course a very important aspect in getting the stakeholders, like Helen told us that she did from the bottom up already with all parties. We do now in the second phase, that it gives a higher level of confidence to the stakeholders if they are the one that are according the system. Then also some other changes were made. In one sentence said, we are less on the data and the figures of the practice itself, but more on the process that comes to it, and on how you organize things and not what you have organized. And that is a main aspect of going into certification. So practice has to do a risk analysis on quality and safety issues. They have to demonstrate how they control the risks. They don't have to give a report on what risks they have met, but on how they control it. And there should be systematically improvements based on measurements, indicators, and that comes very much back to the accreditation system, where you also measure and improve. But the data, for example, how you do your diabetes work is less important than on what do you improve. Then the practice itself is responsible to choose solutions for risks and for the problems encountered. And that means that you don't have the influence on your feedback report is a bit less. The practice is more independent, but also has more responsibility in doing that. That means that, for example, if you look at the infection prevention, we have in the Netherlands an infection prevention protocol, and you could state all the aspects of the infection protocol and say, okay, this practice is working according to the infection protocol or not. But that makes it very rigid, and that makes it also very difficult to have it accepted in practices, because sometimes an aspect in an infection protocol is not so strict as that you would think of. And in your practice you could think, okay, in our practice we have a very good way of organizing it like this. We write it down, we make it part of our protocol, and that would mean that it would go sufficient as well. That doesn't mean that it would allow low quality of care work, I don't mean this, but it gets loose, it gets away from the rigid way of dealing with protocols. So if you look at the system now, we have you can look at the people and means, organization and processes and delivery of care. Most of the certification systems start on the left side of this figure, but this system starts on the delivery of care side. So we still think it is important not to look only at the people and the means or the organization and processes, but I think the delivery of care is the ultimate goal that we do it for, so that plays an important part. So I see there a difference with the UK in this. This may be nice for people in Croatia to think, okay, what would we like to do? Then you get the identification. You don't have to understand all of this, but at least you see that the system is built up like this. For safety and quality, the basic principles are whether they are met, and then the minimum requirements, at least, and they are at a higher level in the certification system than they were in the accreditation system. So people have to commit to higher standards than they should before, because that is what the college, what I was talking about, the independent college, required. So if you look at the audit that is also done every year in this system, the audit will concentrate on the last part of the system. So it will not concentrate anymore on how is the outcomes of your diabetes care, but how do you have your processes arranged to improve it. And that is a difference in the certification system compared to the accreditation system. So what the ultimate goal is, that we can say the patient, so in the accreditation system we would say, okay, we have a professional system of which we as professionals think this is good quality of care, is now translated to the patient can have a justified trust that the practice delivers well considered and safe care. So that's another point of view. You start talking about the patient as a starting point now, and the justified trust doesn't mean that everything has to be perfect, but at least that they can trust that you work on a high quality of care and safety level, and that there are minimum requirements for that. And I think this is a very important standing point, or how do you call that? Then there's some questions, of course, which we are already also struggling with now in this phase of change. We don't know if this flexibility and general standards, how we have to deal with that. How flexible can you be if a practice says, well, this protocol is not of a value for us. We have our own idea. How much liberty do you give those practices? That is something to figure out. We are not... Well, I don't have a very good answer to that, but know at least that this is a question that we think is very important. Then a shift from describing content to processes. How do GPs experience that? They may have the idea that they now have become in a sort of government organization where it's only paperwork and does not reflect anything of their own practice. We know that the feedback reports with data on your actual performance are very much appreciated by GPs. They love to see their reports in relation to the benchmarks. And it didn't disappear, but in the audit it goes a bit to the background. There's a difference in that. So does it affect the satisfaction of the GPs? We don't know yet. And then which procedures should be written down? Because we have about 30% single-handed practices. How extensive should single-handed practices describe the cooperation within their practice? For example, you have one GP and one practice assistant. That's the whole practice. Do they have to write just as extensively these protocols on working together like a large practice with 10 GPs and 20 or 30 practice assistants? Of course, there's a difference between them. And then the risk analysis, what is an acceptable risk and who may decide this? There's this for example, you have this problem on the influenza vaccination, which we had just last month. You are given those vaccinations, you get about 1,000 of those vaccines, and they are numbered in groups. And the protocol says that for each patient, you should know from which group the vaccine comes, because when there is a problem with allergic reaction or anything that is wrong with the vaccination, you should know which patients were there. But the risk of having this problem, it hasn't occurred yet in the number of years we had. So how extensive should you do this in your practice? So, well, you could at least think about a more handsome or more easy protocol for this without stating in every patient that comes for the vaccination, you got this number and you got that number. But for example, you could say, okay, on this day we use this number, on this day we use that number. There's just an example to show that you can work creatively with things, and it depends on the risk that you have, of course. It's a very high risk problem, you have to be more strict. It's a very low risk problem, you can have more flexibility. Then the practice, the auditor is of course someone who plays a role. One auditor may say this is a good idea, the auditor may say, well, I don't agree with that. You can't put it all in a protocol for auditors, so there is some feeling, some gut feeling also in this system, although it's very well described, but there's also some flexibility whether it will be good for the auditor in this case. Okay, this was my presentation. I hope I have given you some insight in our accreditation system and also in our certification system that we are developing right now. And I hope that it gave for our Croatian colleagues an idea of what they may start getting their ideas on. Thank you very much for your attention.